And good morning, everyone. It's my great honor and pleasure to meet you, everybody, here in beautiful city of Kaohsiung. Because we are a little bit behind the time, I will go a little bit fast. Before I start my lecture, can I ask you a question? How many of you are very, very familiar with Nutcracker Syndrome? So, how many of you had the experience, a lot of experience with Doppler ultrasound of Nutcracker Syndrome? How about the diagnosis of the Nutcracker Syndrome using CT? It's fun. Okay. So I think most of you are very familiar with Nutcracker Syndrome, so I'm going to share my experience. So Nutcracker Syndrome definition is a compression of left renal vein between the aorta and SMA, causing renal vein hypertension. Usually it causes gross hematuria due to the rupture of the very small veins and the septum between the small veins and collecting system. But sometimes it causes a microscopic hematuria, proteinuria, instead of gross hematuria. We should be careful in using terminology, the Nutcracker phenomenon and Nutcracker syndrome. It's the Nutcracker syndrome it means that in addition to the phenomenon compression, it needs a symptoms. And there are related conditions. In male is varicocele, and in the female is pelvic congestion syndrome. Is caused by same phenomenon. But the important thing is it's much more common than we thought. But in the history, it begins in 1937 in the anatomic textbook Graham. There is a description of potential compression of left renal vein between aorta and SMA. And in 1972, the name of Nutcracker syndrome was made by Dr. Schaffer. And it usually occurs in the very thin, previously healthy people, like the people like having this body shape, and with a decreased amount of retroperitoneal fat and prominent lumbar lordotic curve. But question is, can Nutcracker syndrome be suspected from these anatomic changes? Maybe yes. We can use the aortomesenteric angle. It is usually around the 90 degrees, rectangular in normal people, and in Nutcracker patients, the angle is narrowed much lower than 90 degrees. We can suspect on the basis of this aortomesenteric angle. Also, we can measure the diameter of the left renal vein in this hilar area and in this aortomesenteric area. But the question is, how narrow aortomesenteric portion left renal vein and how wide hilar portion is abnormal? It's a difficult question, and also in our study there was too much overlap. So it's not easy to use this diameter criteria in diagnosis of Nutcracker syndrome. Also, there are papers that dilatation of this hilar portion of the left renal vein occurs very often, and so almost it's a normal variant in adults and also in our children. So next question we can raise is, can we suspect Nutcracker syndrome from those anatomic changes? Probably the answer is yes, but it's not enough. So still the diagnostic criteria of Nutcracker syndrome is there should be no other cause of hematuria, and there is a high proportion of isomorphic RBC in urine, and in the left side hematuria should be confirmed as cystoscopy. And most important criteria still we are having is the pressure gradient higher than 3 millimeter mercury at venography with the pressure measurement, but it's a very, very invasive procedure to make a diagnosis of Nutcracker syndrome. So the next question is there diagnostic criteria for Nutcracker syndrome better than those anatomic changes like aortomesenteric angle or diameter? It will be for velocity and can be measured at Doppler sonography. So on the basis of this theory, principle of continuity, the product of area and the velocity is usually constant in the ideal and incompressible liquid. Although the blood is not an ideal and incompressible liquid, but we can roughly apply this theory to the diagnosis of Nutcracker syndrome. Usually in this hilar area, the velocity is around 15 to 20 centimeters per second. But because of normal slight compression here, normal value is around 40 to 50 centimeters here. How about this case? In this patient, this area is 22.5 centimeter, okay? But in this area, more than 100 centimeter, very, very high. And in this patient, the venography shows the compression here, and the pressure gradient was 6 millimeter mercury. So we could make a diagnosis in the case, but we need an invasive procedure. How about this patient has a left-sided hematuria and very narrow aortomesenteric portion and narrow aortomesenteric angle, and the normal velocity at hilar area, higher velocity at aortomesenteric area, again the higher pressure gradient. Another case of Nutcracker Syndrome. So we have done studies in both adults and in children, and we measured peak velocity using the Doppler, and we compared those peak velocity in the Nutcracker group and the control group, and found this is the result in adults, and the velocity in aortomesenteric areas was much different. And the cutoff value is best cutoff value around 80 centimeters per second. We can also measure the ratio of the velocity between hilar area and aortomesenteric area, and also significant difference was there. And the best criteria, the cutoff value was ratio 5.0. In children, we did the same study, and the cutoff value was around 93 centimeters per second, and the ratio is 4.7. So to the question, how fast is abnormally fast, probably we can answer that around 80 to 90 centimeters per second. If the velocity is higher than this, it's abnormal, and we can make a diagnosis of Nutcracker syndrome. Then next question is, can we estimate renal cava pressure gradient non-invasively? I think it's a theoretically yes, on the basis of Bernoulli principle. It's the theory regarding the pressure, velocity, and the elevation of the flow dynamics. And the equation is like this one. Here the P pressure, velocity, and H is the elevation, and the low is the density, and the G is the acceleration due to gravity. But in the body, we can ignore the elevation, and then the equation can be simpler, like this one, and then pressure gradient we can calculate on the basis of this simplified equation. And then if the velocity 1 in the velocity aortomesenteric portion is 40 centimeter, and this area, group 2, is 20 centimeter per second, usually normal value, is a theoretical pressure gradient is 0.48. And if this, the aortomesenteric velocity is 80 centimeter per second, theoretical is 2.39, and 150 second, 8.79 millimeter mercury. And if it is 200 centimeter per second, theoretically, pressure gradient is more than 15 millimeter mercury. Let's see the cases. Case 1, 152 second, 52 centimeter per second. Theoretical pressure gradient is around 9 millimeter mercury, but the real true pressure gradient at venography was 6. How about this one? It was the velocity was 112. The theoretical around 5 millimeter mercury. There's venograph 4 millimeter. And how about this one? Theoretical and 2. Another one, theoretical and 2. Here we can find that in most cases, true pressure gradient is lower than theoretical pressure gradient. Why is that? It's probably due to collateral vessels. Because of these collateral vessels, true pressure gradient is usually lower than theoretical pressure gradient. Then the next question is, can we suggest Nutcracker syndrome SCT? Because nowadays, often the first imaging study we are doing is a CT in patients with gross hematuria. Normally, there is a slight compression of the left renal vein between SMA and aorta, and on the shape of this compression, we can categorize in 3 groups roughly. And this kind of shape, we can call it a big sign. If there is a disc finding, big sign, then it has quite high sensitivity and specificity in making diagnosis of Nutcracker syndrome. And this study was done with Dr. Joe. He's here. My colleague is in the same hospital. And we can also measure the big angle. And if this angle is higher than 32 degrees, it means that the degree is higher. It means that the change of the diameter is accurate. And also this finding, this big angle has a reasonably high sensitivity and specificity in making diagnosis of Nutcracker syndrome. So let's see this case. In Doppler, is very high velocity, so we can strongly suspect Nutcracker syndrome in this patient with gross hematuria, and the theoretical pressure gradient is around here, and the CT finding shows a big sign here, and this angle was 62 degrees higher than, very higher than 32 normal value, and the venography, the pressure gradient was 6 millimeters of mercury. So maybe we do not need this invasive venography in this patient to make a diagnosis of Nutcracker syndrome. Another finding we can see on the serial CT images is contrast jetting. In early the cortical phase, we can see the flow of contrast from left kidney through the aortomesomeric portion of the left renal vein. This is normal finding. It's a very smooth movement of contrast with a plug flow. And another patient that's showing the normal flow, the contrast through the left renal vein. And how about this one? It's much different. There is a jet through this aortomesomeric portion. It's much different from the normal flow. Maybe it means that there is a significant narrowing in this area. So this is different from this normal flow, movement of contrast. So normal movement of flow, the abnormal jet. So in this patient, there's a narrowing here and the high velocity through the aortomesomeric portion. Also there is the big sign, the abnormal big angle. Also there is a jet. Then probably we definitely do not need a venography in making diagnosis of this theoretical pressure gradient. So this is a summary of my talk. As Nutcracker syndrome is not a rare disease and it is quite common. And Doppler ultrasound is very, very useful in measuring the flow velocity of the left renal vein, and we can highly suspect the Nutcracker syndrome on this basis of this velocity, and we can theoretically measure the pressure gradient. And the renal cable pressure gradient can be estimated from Doppler velocimetry, and contrast intensity findings such as big sign, big angle, and contrast phenomenon may add specificity to the diagnosis of Nutcracker syndrome. The last thing I would like to say is that possibly we do not need invasive venography and pressure measurement for the diagnosis of Nutcracker syndrome. Thank you very much for your kind attention.